हम्म।
Sir, good morning.
गुड मॉर्निंग।
Sir,
हाँ जी।
Praveen this side from Alchem, sir.
यस सर।
Yeah. Sir, this I have did live on YouTube also. So
ओके
if
सर।
anyone from you can check that it is live or not.
सर एक बार चेक कर यूट्यूब पे लिंक। हाँ, आ रही सर आवाज? हेलो।
Hello.
हेलो, हाँ जी सर, एम आई ऑडिबल?
Yes, yes, you are audible, sir.
इमेज ही कह रहे हैं कि वो इसमें आ रही है यूट्यूब। सर इट इज लाइव ऑन यूट्यूब। प्रवीण जी है ना? हेलो।
Sir, Anand sir, good morning.
गुड मॉर्निंग प्रवीण जी। स्क्रीन इज पॉज्ड, स्टॉप शेयर करो ना इसको ले। इसका लैपटॉप है यार, मेरा ही नया लिया है सर बनाने के लिए। अरे वो ठीक है यार, ये स्क्रीन पे इतना कम छोटा कैसे आ रहा है? बंद कर दो। कैसे करूं? इसको दबाना, इससे क्या था? इससे बगल वाली से। नहीं बनाना बड़ा, एक मिनट दो ना। चलो ऐसे कर लेना, और क्या इसमें, बस शेयर करके वही करना है तो। और क्या है ना यार, यूट्यूब पे ना लिंक जनरेट जो करना वो। हेलो प्रवीण जी। ये कहीं बाहर में छोटा ना हो से। क्या छोटा करना है ये? भाई तो रुक जा, तो कर लूंगा ना, मैं हूं ना। परेशान रहते। हाँ ऐसे कर ले है ना। ऐसे हो जाएगा। अच्छा इस पर क्लिक करके पहले, ठीक है ना, ऐसे कर लेते हैं। पता किस करना, डबल क्लिक से कुछ नहीं करना, छोटा किस कुछ करना, छोटा शेयर करना है बस अपना पे। अभी शेयर करना है हमको यार, ठीक तुमने पीपीटी ऑन कर रखी है ना? हाँ बस ठीक है, शेयर करेंगे। हेलो। इस पे आ रही है ना यार, उधर से कनेक्ट करके बस फुल। तूने इससे कर लिया कनेक्ट? हाँ
स्पीकर से।
कह रहे आवाज आ रही है, वो बता रहे थे मेरे को कि आवाज
अरे नहीं, इससे करना है यार ये।
इस वाले से।
59 हो गया। और
In progress. 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 Progress.
हेलो हेलो हेलो। हेलो हेलो हेलो। इसमें कहाँ से आ रही है?
इसमें तो नॉर्मली आती है।
हेलो
हम्म। मैंने साइड पे करती हूँ बस। प्रवीण जी,
Yes, sir. Good morning.
गुड मॉर्निंग, गुड मॉर्निंग। स्टार्ट करें?
So, yes, sir. It's already more than 8 o'clock. So we can start, sir. We are live on YouTube and Zoom as well. So,
Okay, thank you. Thank you. So a very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a presentation on locally advanced and metastatic prostate cancer. This will be presented by our resident, Dr. Keshav, and would be moderated by our faculty, Dr. Kuldeep. So I would request Dr. Keshav to kindly share his presentation. Good morning, everyone. I am Dr. Keshav Palia. Today's seminar is on locally advanced and metastatic prostate cancer management. Tumors with spread outside of the prostatic capsule, T3 stage, or involvement of adjacent organ, T4 stage, or any lymph node involvement without distant metastasis are included in the locally advanced. At least 10% of newly diagnosed CA prostate will have locally advanced prostate cancer. In T3 stage, tumor palpable and through the prostatic capsule, and T3A is extracapsular extension, and T3B is tumor invaded seminal vesicles. T4 is a fixed or invaded tumor adjacent structures other than seminal vesicle, like external sphincter, rectum, levator muscles, or pelvic wall. In N0, no regional lymph node, and N1 regional lymph node metastasis. Regional lymph nodes are a pelvic group of nodes, and external common iliac and above nodes are considered metastatic. In NCCN risk stratification, high risk categories are clinical stage T3A, Gleason score 8 to 10, and PSA more than 20. In very high risk clinical stage T3B, T4, primary Gleason pattern 5, and Gleason score 8 to 10. EAU also classified biochemical risk groups for biochemical recurrence for localized and locally advanced prostate cancer. In high risk group, any PSA, any Gleason score with T3, T4, or M node positive is considered locally advanced. The investigation for locally advanced prostate cancers are local investigation. Investigation for local staging are bone scan, T3, T4, PSA more than the indication for bone scan is T3, T4 stage, PSA more than 20, Gleason score more than 8 or more than 8. Pelvic CT or MRI, T3, T4, the indications are T3, T4, calculated probability of lymph node involvement is greater than 10%. EAU also recommend PSMA PET CT for high risk localized disease and locally advanced disease. Why PSMA PET CT? Because PSMA PET CT have sensitivity specificity 96 and 99% compared to bone scan, which have 73 84%. And marrow and lytic skeletal metastases are missed by bone scan. The algorithm for the treatment of locally advanced disease is EAU recommends external beam radiotherapy and ADT for androgen deprivation therapy for 3 years and with the abiraterone for 2 years. Preferred treatment, and in a few selected cases, radical prostatectomy with extended pelvic lymph node dissection. If patient is not fit for abiraterone, and external beam radiotherapy with ADT can be given for 2 to 3 years. And in node positive disease, external beam radiotherapy also given to the pelvis also with androgen deprivation therapy for 3 years and abiraterone for 2 years. Radical prostatectomy with extended pelvic lymph node dissection are reserved for a low volume tumor that can be completely excised. Surgery has selected patient for T3 disease with low volume disease that may benefit, and adjuvant and combined therapy also required. Without secondary treatment, biochemical relapse is higher. Pathological parameter predicting progression, prostatic extension of the tumor, seminal vesicle involvement, lymph node involvement, and positive surgical margin on pathology. Role of neoadjuvant androgen deprivation therapy affects tumor behavior and biology. Reduction in positive surgical margin in T1, T2 diseases and on T3 disease do not support benefit of neoadjuvant androgen deprivation therapy. Clinical downstaging may occur, but there is no difference in pathological downstaging. Similar rates of positive margins. Neoadjuvant chemohormonal treatment decreased overall positive surgical margins, pathological downstaging, decreased biochemical relapse, and decreased local recurrence. The regimes for chemohormonal treatments are 2 6-weekly cycle of ketoconazole with doxorubicin, alternating with the vinblastine and astramustin, and Texans with androgen deprivation therapy, astramustin and carboplatin. Docetaxel can be given with a single agent only for 6 cycles. Adjuvant radiation therapy improved biochemical control, significant reduction in local recurrence, and low risk of metastatic disease, improved overall survival, freedom from subsequent androgen deprivation therapy. Early adjuvant radiation therapy administered within 3 to 6 months of surgery, with early adjuvant radiotherapy administered within 3 to 6 months of surgery with undetectable PSA. Treatment adjuvant radiation therapy treatment benefit primarily seen in positive surgical margin. In seminal vesicle invasion, significant risk for distant metastasis may not benefit for local or regional radiotherapy. Seminal vesicle invasion who achieve a low PSA level after radical prostatectomy are favorable group, and adjuvant radiotherapy may be considered for this group of patients. And adjuvant androgen deprivation improved overall survival, cancer-specific and progression-free survival. Adjuvant androgen deprivation with radiotherapy improved survival when compared to single adjuvant androgen deprivation therapy alone. This is the NCCN guidelines for prostate cancer. If patient survival is less than predicted survival is less than 5 years, or he is asymptomatic, observation alone with radiotherapy or angiotensin deprivation therapy with radiotherapy can be given. In some expected survival more than 5 year or symptomatic patient, radiation therapy with an ADT for 12 to 36 months, or radiotherapy with ADT with abiraterone for very high risk group of patients, and radical prostatectomy in low volume tumors in if there is a undetectable PSA, there is or PSA persistence, we will see in the PSA persistence group. For node positive disease, radiotherapy with androgen deprivation therapy for 24 months and abiraterone preferred in, and there is if a patient is not candidate for radiotherapy, androgen deprivation therapy with abiraterone also given. In radical prostatectomy in selected group of patient with extended pelvic lymph node dissection done. If patient survival is less than 5 years, there is observation and radiotherapy with androgen deprivation therapy plus minus RT can be given. What is biochemical recurrence? After treatment, PSA is usually tested at 6 weeks and then at 3 monthly interval for 1 to 2 years. Thereafter, the test may be repeated less frequently if it is not rising. After radical prostatectomy surgery, the PSA should become undetectable on the standard PSA test. After surgery, PSA above 0.2 nanogram per ml is called biochemical recurrence, and BCR is continued if the PSA is elevated or rising on 2 or more consecutive tests. After radiotherapy, continuous rise in PSA above the nadir value, particularly if it reaches above 2 nanogram per ml, is called BCR. In radical prostatectomy group with PSA persistence, if life expectancy more than 5 years, risk is stratification that we have seen, bone and soft tissue imaging done, and prostate bed biopsy done. If studies are negative for pelvic nodal recurrence and distant metastasis with or without positive fossa recurrence, EBRT, external beam radiotherapy with ADT are preferred treatment. If studies are positive for pelvic node recurrence, EBRT with ADT or with abiraterone can be given. If studies are positive for distant metastasis, we will see in the metastatic group of. If radiation therapy BCR, PSA recurrence or positive DRE, risk stratification done and bone and soft tissue imaging are done. Studies negative for regional lymph node and distant metastasis. Consider prostate seminal vesicle biopsy for monitoring, and ADT based on the PSA doubling time. For local secondary therapies are given but not a preferred treatment. Studies positive for regional lymph node consider prostate and seminal vesicle biopsy or monitoring or ADT with or without abiraterone. These are the few recommendations for locally advanced disease by EAU guidelines. Radical prostatectomy offer radical prostatectomy to the patient with N0 disease as part of multimodal therapy. In patients undergoing a lymph node dissection, you should perform an extended pelvic lymph node dissections. Other offer patients with N0 disease intense IMRT, volumetric modulated arc therapy with plus image guided radiation therapy in combination with long-term ADT. Offer long-term ADT for at least 2 years. Offer IMRT of VMI volumetric modulated arc therapy plus IGRT to the prostate with pelvis in combination with long-term ADT and 2 years of abiraterone to the node positive diseases. Do not offer whole gland treatment or focal treatment. For second line therapy after treatment with curative intent, offer early salvage intensity IMRT with to the man with 2 consecutive prostate PSA rises. Do not wait for a PSA threshold before starting treatment. Once the decision for salvage radiotherapy has been made. SRT at least 64 grays should be given as soon as possible. Offer salvage radical prostatectomy, brachytherapy, stereotactic body radiotherapy, high intensity HIFU or cryosurgical ablation local therapies in a highly selected patient with biopsy-proven local recurrence within a clinical trial setting or a well-designated prospective study undertaken in an experienced center. I do not offer ADT to M0 patient with a PSA doubling time more than 12 months. Now the management of metastatic prostate cancer. M1A is non-regional lymph node involvement. M1B is the bone involvement, and M1C is the other site involvements. M1C is the most advanced category. In many cases, the only manifestation of a disseminated disease is an elevated or rising serum PSA following definitive local radiation therapy. However, some men with prostate cancer have overt metastasis and present with the mets only. In the vast majority of cases, such metastases are predominantly osteoblastic lesion in the axial skeleton. The metastatic diseases are grouped in the two groups by charted trial with volume more than 4 bone mets, including one outside vertebral column or pelvis, or visceral metastases are considered a high volume disease. And by latitude trial, risk stratification are there, but for treatment purposes, we only use charted trial. The management of metastatic disease is continuous castration. With if a patient have a adequate life expectancy, and if it is a low volume disease, there is after ADT there is a external beam radiotherapy given to the prostate only. And if a patient is eligible for docetaxel, double combination therapy in a form of ADT with abiraterone or ADT with docetaxel given in high volume diseases with more than 4 bone mets, including one outside vertebral column or pelvis or visceral mets. Triple regime therapy are given in the ADT, abiraterone with docetaxel. Now, a few points about ADT, androgen deprivation therapy. Orchidectomy, agonist versus antagonist are decided by the patient's factor, by his functional status, if he is taking any blood thinner or cardiac history, and the finances of the patient, or disease factors by if there is an impending cord compression or severe voiding loads are there. This is the androgen pathway. Gonadotropin releasing hormone secreted by hypothalamus and acts on pituitary and secreted. The GnRH antagonist works on the on hypothalamus GnRH, and GnRH agonist work on pituitary, and GnRH secreted in the pulsatile manner. And if GnRH agonists are there, there is a continuous bilateral orchidectomy. Rationally, the 95% of testosterone is produced in the testis. Advantage is fastest to reach castration level within 6 to 12 hours. Very economical. This one-time procedure can be performed under local anesthesia. Disadvantages are permanent castration, occasional patient with a wound infection, and scrotal hematoma, or with psychological issue. In these patients, subcapsular orchidectomy or epididymal sparing orchidectomy can be tried. GnRH agonist, sustained increase in level of GnRH in contrast to physiological pulses, downregulation of GnRH receptor in the pituitary, decrease in production of LH and FSH. The initial increase in GnRH causes a flare phenomena. This lasts for 15 to 20 days, needs to be covered with anti-androgens. Bikilotomide 50 mg/OD are given for 2 to 3 weeks. Castrate level are achieved in 2 to 3 weeks. Various formulation of GnRH agonists. Leuprolide are 22.5 mg given 3 monthly or 45 mg 6 monthly, subcutaneous or intramuscular route. Triptorelin 11.5 mg 3 monthly or 22.5 mg to 6 monthly intramuscular route. Gocirolin 3.6 mg monthly or 10.8 mg 3 monthly. The annual cost for patient is 40 to 60,000 rupees. GnRH antagonist, suppression of GnRH level, decrease in LH and FSH. There is no flare phenomena in antagonist. LH level falls by 84% within 24 hours. Castrate level in 90% patient achieved within 10 days. Injection site reactions are known because it is subcutaneous injections. Loading dose is 240 mg and maintenance dose of 80 mg monthly given. Subcutaneous administration annual cost is slightly higher than agonist. 1.5 lakh in first year, then 1 lakh because of the loading dose. Recently, an oral antagonist relugolix was approved. Cardiovascular risk with agonists are GnRH agonists lead to an increase in LH and FSH. Increased FSH has been postulated to lead to plaque rupture and cardiovascular events. This risk is especially higher in patients who already have a history of cardiovascular events. Orchidectomy also leads to higher FSH. However, its side effect on cardiovascular disease has not been extensively studied in Western literature because in Western they don't do orchidectomy; they use medical castration only. This is a paper comparing agonist and antagonist cardiovascular morbidity. And in this paper, a man with pre-existing cardiovascular disease at significantly fewer cardiac events or deaths in patients receiving GnRH antagonist compared to agonist. And a man with no pre-existing cardiovascular disease at baseline, though no differences in the incidence of cardiac events. Other options for ADT is bicalutamide monotherapy that acts on the androgen receptor directly. Used in the past, ketoconazole inhibition of androgen synthesis or Honovan 120 mg thrice a day. But these are reserved for the CRPCs, not used directly. Which modality of ADT to choose? If there is vertebral mets with impending cord compression, we have to achieve the castration level, hormone castration level soon. So orchidectomy or antagonist are preferred. If large glands with severe voiding loads, orchidectomy or antagonist are preferred. In high risk of cardiovascular events, antagonists are preferred because the status of orchidectomy are not known. None of the above factors are decided based on the affordability of patient and hospital. Intermittent ADT, intermittent ADT can be given in if severe side effects are there, but in metastatic disease, it is advised to continuous ADT. Do we have to cover with bicalutamide if switching from Degarix or Degarix to agonist? No, there is no need. And hot flushes are the common side effect. The treatments are megestrol acetate 40 mg, SSRIs, and pregabalin. Abiraterone, Stampede, and Latitude trial are there for comparing ADT alone or ADT with abiraterone. Dose is 1 gram once a day on empty stomach with 5 milligram prednisolone. Benefit irrespective of low or high volume disease. Specific side effects are hyperglycemia, water retention, hypokalemia, lipid disturbances, and LFT derangement. This is this is a pathway where the abiraterone works on 17 alpha hydroxylase and 1720 lyase. So the pathway breakdown and on there is a more cholesterol for aldosterone. Docetaxel trials for docetaxel is Stampede, Charted, and GETAC 15. In Stampede and Charted trial, there were 6 cycles are given, and in GETAC 15 to 9 cycles are given. Well, dose for docetaxel is 75 mg per meter square for 6 to 9 cycles. Very infrequently used nowadays for low volume HSBC, most toxic to all options we have available. This is a comparison between abiraterone and docetaxel. In poor functional status patients, abiraterone is preferred. Duration of treatment for abiraterone is till disease progression. In docetaxel, there are 6 cycles. Cost for docetaxel is higher. In diabetic patients, in uncontrolled diabetic patients only, docetaxel are preferred because abiraterone in renal failure patients, abiraterone are preferred. In hepatic insufficiency, docetaxel are preferred. In for hypertension, docetaxel are preferred. If these are only uncontrolled type of hypertension and diabetes only. For enzalutamide, the Archies and Enzamet trial are there. Dose is 160 mg OD. Some patients in both trials received enza with docetaxel. Specific side effect is cognitive disturbances and propensity to fall because it crosses blood-brain barrier. This is the table comparing abiraterone, enzalutamide, epletamide, and darolutamide. Abiraterone taken on empty stomach, enzalutamide taken with or without food, in epletamide taken with or without food, and darolutamide taken with the food only. Radiation therapy to the prostate because we want to hit the primary after ADT are given for all low volume diseases, and there is a HORAD and Stampede trial. 6 months later, after the 6 months of ADT are given, and 72 grays are given in 36 fractions, and it is given only to the prostate, not for the whole pelvis or nodes. For radiotherapy to the metastatic sites, the evidence only in CRPC and in oligorecurrent prostatic carcinoma. STOMP and Oriole trials are there for this, and no oncological benefit in hormone-sensitive prostate cancer progression. For pain at metastatic site, palliative radiotherapy can be given for 8 to 10 grays on multiple sites can be given, and it can be repeated. For hematuria, these are the complication management for metastatic carcinoma. For hematuria, androgen depreciation therapy works on the hematuria. If it is not controlled, then channel TURP can be done. Hemostatic radiotherapy, or if nothing, then angioembolization. The bone health of the patient are 3 elements detrimental to the bone health for this type of patient. As these patients are advanced age, so age-induced osteoporosis, bone mets, and cancer treatment-induced bone loss are there by ADT and continuous steroids. There are EAU, NCCN recommendation for this. DEXA scan for baseline at ADT initiation. DEXA is recommended for most patients in selected individual at low probability of fracture based on FRAX score. This is available online. DEXA can be omitted. If patient is on ADT, then DEXA every 1 to 2 years depends on the FRAX score. And if patient is on anti-resorptive therapy, DEXA at every annually done. In patients of all patients receiving ADT have to advise for lifestyle modifications like weight-bearing exercise for 30 minutes per day, and balance training, and limit alcohol consumption and smoking cessation. Calcium and vitamin D supplementation are given for 1000 to 1200 mg daily from with food and from food with supplements if needed, and maintain serum vitamin D3 level 30 to 50 nanogram per ml. For treatment-related bone loss in patient receiving ADT, anti-resorptive therapy in forms of alendronate 70 mg per hour weekly, or denosumab 60 mg subcutaneously every 6 months. Zoledronic acid 5 mg IV annually are given. For prevention of symptomatic skeletal related events in patients with bone metastatic CRPC, anti-resorptive therapy is given. Denosumab 120 mg every 4 weeks. Zoledronic acid every 12 weeks. The DEXA scan is easily available, and get a DEXA scan before starting long-term ADT. The caveat is sclerotic bone mets gives a falsely high T score. Few things about zoledronic acid is dental checkup is mandatory because it causes a osteonecrosis of the jaw. So 2 to 3 week gap between dental extraction and initiation of the therapy. Check renal function. It is not recommended if GFR is less than 30. Slow infusion is given because the risk of hypocalcemia. And another option is subcutaneous denosumab 60 mg every 6 months. Zoledronic inhibit osteoclast function, and for osteoporosis in HSPC more 5 mg 100 cc infusion once a year, and for CRPC 4 mg 100 cc infusion once every month. If patient comes on a stretcher, there is a concern of loss of power or just pain. We have to inquire about the duration of symptoms. DEXA 10 mg given state, MRI spine, and neuro and ortho referrals neuro reference are done. Androgen deprivation, because we have to achieve the castrate level castrate level hormones level. So no agonists are given. Guarded prognosis on limb recovery. Offer anti-resorptive therapy to men on this is EAU guideline. Offer anti-resorptive therapy to men on long-term ADT with either a T score less than 2.5 or with an additional clinical risk factor for fracture, or when annual bone loss on ADT is confirmed to exceed 5%. This is the NCCN guideline for metastatic CSPC. If low volume synchronous metastasis, ADT with one of following: ADT with abiraterone, ADT with epleiptolamide or enzalutamide, and other recommended regime are now durolutamide. Or ADT with docetaxel is not preferred treatment. In low volume metachronous mets, ADT with ADT with abiraterone, epleiptolamide, enzalutamide. For high volume disease with synchronous metastasis, triple therapy is given. ADT with abiraterone, darolutamide, and epleiptolamide, enzalutamide, or with physical examination are done. Physical examination and PSA is done every 3 to 6 months, and imaging for symptoms. When to get a PSMA PET scan? When the serum PSA starts rising. Few things about genetic testing. Genetic testing is recommended for patients with high risk, very high risk regional or metastatic prostate cancer, and those with a family history of high risk germline mutations. Testing recommended to include MLH1, MSH2, MSH6, PMS2, and homologous recombination genes, BRCA1, BRCA2, ATM, PLB2, and JAK2. And by tumor, testing for MSI should be considered for regional or MHSPC and advanced tumor, and is recommended for metastatic CRPC. Testing for HR gene mutations, homologous recombination genes mutations should be considered for regionally advanced tumor, and is recommended for metastatic diseases. We thank you, Charles B. Huggins, because his paper led to the androgen deprivation therapy used nowadays.
Which year it was?
49.
Not 40. It was 48, I think. Anybody can check, probably, yes. Anyway, thank you. Keshav. And I think this is again very important and hot topic. Locally advanced metastatic prostate cancer. So what we need to differentiate is whether we are getting a de novo locally advanced prostatic cancer or metastatic prostate cancer, or it is occurring after a definitive therapy, right? So after definitive therapy, you can have a local recurrence, locally advanced tumor, or metachronous metastasis. So this is important to differentiate. And secondly, I think we need to know that, yes, locally advanced prostate cancer, uh, how would you just do the imaging? He said about all the imaging studies. So there is a conventional imaging, CT abdomen and chest, and a bone scan. And the other is a next generation imaging, which will include PSMA PET CT and a whole body MRI. So we need to uh, try to find out which patients would require which type of imaging. So once you have done the imaging, you have the serum PSA level and the histopathology, which tells you about the variant pathology if possible, and whether there's an intraductal carcinoma, where there's a AR splice variant present or not, and the Gleason scoring, definitely. So all this will help you to try to risk stratify the disease. So once we have done the risk stratification and the staging of the disease after all these investigations, then we need to know exactly the other patient factors, the performance status of the patient, the expectations of the patient, and the finances also, and the availability of the treatments. And that will actually guide you which treatment to give to which patient. So nowadays, we cannot give a blanket kind of a therapy to every patient of locally advanced or say metastatic prostate cancer. We need to phenotype these patients. And personalized therapy is very important, considering all these factors that I told you. Again, so nowadays for locally advanced prostate cancer, we all know that, yes, the treatment of choice would be neoadjuvant hormonal therapy followed by radiotherapy or radiotherapy alone in some of these patients. And the metastatic prostate cancer, which could be hormone sensitive or castrate sensitive and castrate resistant. So once it is castrate sensitive only, then we definitely have to give the patients are docetaxel eligible, then we need to give the triplet therapy. Otherwise, if not eligible, we give the doublet therapy where we give ADT plus either abiraterone or enzalutamide or darolutamide. So in some studies, they say darolutamide plus ADT would be a better choice. Then you have to actually find out, depending upon the side effects profile of the medication, plus the patient's problem. So if suppose the patient is diabetic, we probably would not prefer giving abiraterone. If the patient has cognitive problem, then you would not give enzalutamide. So depending upon all these factors, you decide which treatment to give to which patient, right? Another thing important is about the genetic testing. We need to do in a majority of the locally advanced and metastatic prostate cancer. And plus the history of family history, again, is very important. Plus the intraductal malignancy is there, or AR splice variant is there or not. So all this, and then the racial differentiation, some Ashkenazi Jews, they are probably more prone to develop this kind of aggressive prostate cancer. So all this will help us to know whether this patient would require kind of immunotherapy. So besides the hormonal and chemotherapy and the targeted therapy we know of, there is a immunotherapy where whether these patients are eligible for PARP inhibitors, olaparib or not, that is important. Plus, some of these patients who have mismatch repair deficiency and microsatellite instability, they might require anti-PD-1, which is pembrolizumab. So I think all this has to be properly investigated, and a patient should be properly treated in a more phenotyping manner or a personalized manner rather than a blanket kind of a treatment. one thing is very important, the supplementary therapy, as I said about the exercises, particularly the resistant exercises, which are very important. Most of these patients may not require these denosumab or zoledronic acid, etc. They are usually given in patients with castrate-resistant prostate cancer, or where you see that the skeletal related events might happen in this particular patient. Otherwise, these resistant exercises help a lot. The vitamin D supplementation, the stopping of smoking, etc. And then there are two more things which you missed is many people would give statins and metformin. They say the metformin and statins really help these patients in improving the total quality of life. So again, the most important thing, I think, if you go into the literature and find out what was the maximum survival in a patient with prostatic prostate cancer. So anybody's guess? After diagnosing metastatic prostate cancer, do you think how many years a person can survive?
18 months, 2 years.
So the usual survival is, they say, around 5 to 6 years maximum. But depending upon whether this is a castrate resistant, castrate sensitive, and whatever it is, and whether the patient has been given definitive therapy or not therapy. So the 5 year survival could be this, but there are cases where the patient has survived till 23 years, right? So just I was reading the name of the patient is Mr. Derry Boughton, I think. So he survived. He was diagnosed in prostate cancer in the year 2002 and is still surviving, right? So the treating physician had told him that your survival is around 5 to 6 years, but you do not know. It all depends upon your attitude, right? So again, a very important thing is whether the will to live, right? The desire to live and your attitude towards life also matters a lot in these patients. And there are cases where they have survived even 1 or 2 decades, right? After metastatic prostate cancer. So I think that's it. Residents and faculty, anybody has anything, any comment to make? Dr. Nachiket, you want to make any comment?
Sir, actually, we are seeing many patients who are offering around a PSA 4.5, 4.5, what numbers.
Yeah,
With my personal practice, I are seeing a lot of patients. So
yeah.
maybe we should cut down the time. When I talk anything above 3, I start getting PHI 3 PSA done.
All right. So one is that after at 4 or 5, Dr. Nachiket says that we are getting a lot of patients with 4 or 5 PSA with prostate cancer. But I tell you, between 10 to 20, we are getting metastatic prostate cancer.
Yes.
And yesterday only I saw a patient, 43-year-old. 43-year-old, he has metastasis, bone metastasis, more than 4 months. It's a high volume metastatic disease at 43 years of age. So the reason why the screening at 40 is important. See, some of these patients, though they may be very rare, specific subset of patients. No family history. Patient, I asked him so many times, no family history, nothing, no family history of any cancer even. So you don't know. So at 40, getting a PSA can actually help you how to monitor these patients. If you think the PSA is more than 1.5 at 40, they should be very closely monitored. And you may get sometimes even the prostate cancer at this age. So anybody has anything? Okay, so then we will go to our MCQs. You have MCQs, right?
Yes.
Yes, go ahead. So first question is the current appropriate dose of adjuvant radiotherapy after radical prostatectomy is less than 45 grays, 45 to 50, 51 to 55, 56 to 60, greater than 60.
45 to 50.
Huh?
44 is greater than 60.
It's greater than 60. Greater than 60 is yeah. So greater than 60 means between 60 to 80. People are giving till 80 grays also. So there is a trend to improve response to adjuvant radiation therapy, and most contemporary series report doses greater than 60, with potential threshold of either 61.2 to 64 grays. Similarly, primary radiation therapy improved outcomes have been shown for higher doses, 78 grays even. Right. After radical prostatectomy in those with local regional disease, overall survival may be optimized by adjuvant treatment with androgen deprivation, radiation therapy, Sipuleucel T, docetaxel, radiation therapy plus androgen deprivation. Overall survival may be optimized by adjuvant treatment. If there is a local regional disease still after radical prostatectomy, then I think radiation therapy plus androgen therapy would be a better choice. Yes. But again, you have to see that it should be given, radiation therapy should always be given after 3 to 4 months, because the patients may be incontinent. So if you give radiation therapy immediately after, the life could be hell. Yes.
Sir, this radiation therapy after 3 to 4 months, of course, from my understanding is that you can even delay it till 2 years. Because the most important thing is for the patient to be continent. Because if the radiation left here, then there are no chances of him regaining continence. And maximum androgen blockade culture effect those are correct. So even if you defer it to 1 year, 1.5 years, then at that time also they say that because the hormone sensitive hair. So they say that 3-4 महीने के बाद भी you can wait for 1 year.
So depending upon the patient, if the patient doesn't improve his continence, even after 3 to 4 months, which is the usual thing, majority would improve in today's era of radical robotic and radical prostatectomy. But if they do not, then definitely we can defer it even further. Yes. So what are we showing here? A 65-year-old man underwent a radical retropubic prostatectomy 4 years ago for a PT3A N0 Gleason 8 disease. 2 years post-operatively, his PSA first became detectable and has slow rise since then to its current value of 1.2 nanogram per ml. First began as a CT scan of the pelvis is obtained and is depicted above. The most likely. So this is the CT scan of the patient. What does it show? So this is showing some local recurrence. Yes.
It's local site recurrence.
Local. He was radical prostatic already has been
Already
done,
has
right?
been done.
So there is some recurrence. And are we getting some lymph nodes here?
No, about the influence. They need 3A means
What are they?
physical involvement. So that would be more chances of local recurrence. And 1.3 that means biochemical failure. Most common cause of biochemical failure after T2 is the local dip.
So it could be a kind of a metastasis also plus this, but here it is showing there is a recurrence. So probably this is due to recurrence.
Because there is no chance of recurrence in the prostate maybe. N0 था ना?
N0 था.
So there is chance of recurrence in prostate maybe.
Yeah. All right. So the only thing is, what was the post-operative histopathology report? Was it margin positive? What the seminal vesicles actually involved? Pathological diagram. Pathology T3A. T3A means there was some extra caps. No, not seminal vesicle. It was extracapsular invasion. So the seminal vesicles were not involved at that time. And right. So the most likely diagnosis is a retained seminal vesicle, enlarged lymph node, recurrence in prostatectomy bed, rectal mass, rectal diverticulum. Is it a prostatectomy bed?
Recurrence in prostate.
Bed, that is correct. A mass in the prostate on the right at the level of the urethral vesicle anastomosis, because the mass is anterior to the rectum, it is not likely to be a lymph node or seminal vesicle. In view of the radical specimen in the rising PSA, the mass is likely a prostate cancer recurrence in the prostatectomy bed. Another thing important after giving you are giving this triplet or doublet therapy in a metastatic hormone naive prostate cancer, you must know how the PSA is behaving,
Yes,
right?
very-
And the serum testosterone level also is important, right? So
And the doubling time.
and the doubling PSA doubling time,
Very-
oh, that is after when once there has been a recurrence. I'm talking about once the patient is given kind of ADT plus the other therapies. So if the PSA at 6 months is less than 0.2 nanogram per ml, then the prognosis is better. If the PSA is more than 4 nanogram still at 6 months, then the prognosis is worse. So this is again very important, how to monitor the serum PSA after giving this therapy.
So can I make a?
Yes,
There
please.
is a question that he has put up by showing a CT scan, that also is fundamentally skewed. Because if there is a biochemical recurrence, 1.2 with a biochemical recurrence.
Okay, a radical prostate.
So the follow-up to modality here, it is now a toss-up in a DSA PET or a multiparametric MRI able to show a local. So getting a CT scan these days, I mean, this is a base question of old edition. In a
Yeah,
follow-up, you should do a PSA PET.
PSMA PET.
MRI follow-up.
Hmm.
MRI, this is being fundamentally now.
Yeah, nobody does a CT scan only to do a monitoring.
It's a very poor investigation.
CT scan, nobody does.
Very
Yes, very good point brought out by Dr. Nachiket. That CT scan as a monitoring investigation in follow-up is probably not correct. In men with locally advanced high-risk prostate cancer, the most effective treatment among the following option is brachytherapy plus external beam radiation therapy, neoadjuvant AD plus external beam radiation therapy, neoadjuvant plus external beam plus adjuvant AD. Okay, what is that? Plus adjuvant. Once you have given a neoadjuvant AD, how does it become adjuvant AD? Anyway, concurrent AD plus external beam radiation therapy and long-term AD alone. So a locally advanced high-risk prostate cancer, you should, I think, neoadjuvant AD followed by radiotherapy is the best choice. And
Yes.
whether this should be external beam or a brachytherapy or a combination of brachy plus external beam is a matter of, I think, yes.
The adjuvant, adjuvant deprivation ki dena. After neoadjuvant, being external beam therapy, and then we have to continue the.
No. Once you continue, the neoadjuvant has to be continued for 3 years. So what is the mean of what?
DC में
नहीं सी क्यों होना चाहिए एडजुवेंट का क्या मतलब हुआ यू आर ऑलरेडी गिविंग एडी फॉर 3 years तो आफ्टर रेडियोथेरेपी आर यू गिविंग एडजुवेंट और द न्यू एडजुवेंट इज बीइंग कंटिन्यूड
वो सर even though the neoadjuvant is being put into adjuvant and different.
आई डोंट थिंक सो आई डोंट
फिर
थिंक
DC में क्या फर्क होगा सर?
हाँ
B और C में फिर गलत है, फिर C होना चाहिए सर.
हाँ या तो बी और सी का आई एम लिटिल कंफ्यूज्ड अबाउट द सी वो when it's already given a new adjuvant either you give just radiotherapy followed by adjuvant radiotherapy. That can be understood.
This again is
But-
very, I mean, once you started, then it's.
So again, your answer is correct. Anyway, so they meant probably that the accumulated data for radiation therapy oncology group and European Organization for Research and Treatment of Cancer trials suggest that the improved outcomes are achieved with greater duration of administration of androgen in combination with external with apparent benefit for both neoadjuvant and adjuvant therapy. So the question is,
This, there is just no point of only giving as a. Have to continue that adjuvant treatment. At least minimum of 2 years.
3 years. So it is. So I think the question is a little confusing. Anyway, what have the AUA and European Association of Urology determined as the definition of PSA failure following radical prostatectomy? So any level detectable PSA following radical, 2 values of 0.1 nanogram, 0.2, 0.2 with a confirmatory value 0.4. So it cannot be 0.4, it is 0.2, or some people have even gone for 0.1. So it is something. So 0.2 is the usual. 0.2 is the usual. Yes. Which of the following non-steroidal anti-androgens is associated with interstitial pneumonitis and a delayed adaptation to darkness after exposure to bright illumination? Yes. Nilotamide,
Yes.
D. Yes. So about 1/4 of men on nilotinib therapy, I think nobody does that nilotinib therapy. Is it available or not? I do not know. But once I think because around 15 years back probably, they had some studies with nilotinib therapy, but no more. So that's it. Compared with deferred ADT, early ADT instituted before the development of objective metastatic disease provides an overall survival advantage in all clinical disease states, as an equivalent quality of life, doesn't increase overall death rates, doesn't prevent the emergence of CRPC, should be. So this is, you're finding out the true, right? Instituted, okay, compare with. Okay, should be offered to men with PSA recurrence after radical prostatectomy because of rapid disease progression in this clinical setting. Early definitely provides an overall survival advantage, isn't it? Huh? What is the answer? So doesn't prevent the emergence of, so definitely it doesn't prevent. So that is true, no doubt. D is definitely true. So yes. I think that time CRPC, it is not prevented whether if you give early or deferred, right? CRPC will occur in 100% cases. The timing of the initiation of it, what is the cause? Anyway, why does CRPC? Huh? How does the tumor biology change? First of all, there are 3 cell lines, right? One is androgen sensitive, one is partially resistant, androgen resistant, one is the stem cells, right? So it is only the androgen sensitive which is taken care of by the androgen. So the other 2 cell lines can start working anytime. So that is the result which causes gastrate resistance, plus the androgen receptor pathway alteration, the androgen receptor mutations, all this would lead to gastrate resistance, right? So that was the, okay, right. Thank you. So anybody has any questions to make?
I only comment is that your questions, Joanna. All of you these days, you are just cutting and pasting from Campbell's. I'm not specifically talking about just you.
Nachi, can you come here because it's online? Yes. So Nachi wants to make a point and give your. Go ahead.
So what is happening is that you just in a pasting and questions from Campbell's and bringing them in the, and they're ever changing, especially CA prostate is so rapidly changing that in a, then, once we do wrong question and answers, then it gets imprinted. So what I feel is that you should go through the text, read. If you read the text, you yourself will be able to pick up 10 questions. And I'm not talking about you. Maybe this is a critique of the previous seminars also. I mean, there's a tendency to just take the questions from that Campbell Medium book and or Campbell Review MCQs and just cut and paste them. So I think that that's a little wrong. And maybe if you make questions on your own, it will benefit all of us. This is what.
I think important point, because these MCQs actually, which we do it at the last, probably that is the thing which gets imprinted in a brain also. So which may give you a wrong message also. So try to get all those of the latest. All right. Don't have those because this management of CA prostate is changing every month probably, right? Every month or maybe every year at least, right? So you have to take those latest MCQs, try to take those. And as I told you, the stat pearls are very important. Stat pearl में आप जाओगे तो you will get the latest topic with MCQs given also. So you have MCQs in the stat pearl those articles, right? So I told you to try to see those stat pearls. And Campbell Urology, which was probably at least 5 years behind, right? So don't always stick to Campbell's Urology. It is Bible of urology, but it is not because in today's era when every year things are changing, you cannot stick to what campus urology says only. Thank you. So if nobody has any answer, any comment to make, we would wind up the session. And thanks all of you, all residents, faculty, and those who might have joined us today. Thank you very much. Have a good day.